All right, team, let's get started with rounds. Attending, I've got a really fascinating new admission to present to you today. We're going to walk through the case of a 65-year-old never smoker. And honestly, this patient perfectly illustrates the entire diagnostic framework for interstitial lung disease, or ILD, and highlights the mimics we absolutely cannot afford to miss.
For our roadmap this morning, we'll cover the admission presentation first, then do a deep dive into the ILD framework, map out our assessment and treatment plan, and wrap up with disposition and some high-yield pearls.
So, Act 1, the admission presentation.
Our patient is a 65-year-old woman who came in with an insidious 8-month history of progressive exertional dyspnea. Now, importantly, she is a never smoker. This dyspnea started out pretty subtly, but over these last 8 months, it's gotten to the point where she's breathless just trying to climb a single flight of stairs. She also has this nagging, dry cough that gets worse when she lies flat. But zero fevers, zero weight loss, which is great because that steers us right away from acute infections or malignancies. On physical exam, listening to her lungs, you hear these fine, bibasilar Velcro crackles. These are classic. They literally represent the physical snapping open of fibrotic, non-compliant airways during inspiration, which highly suggests structural fibrotic changes. We also caught some mild digital clubbing. We went ahead and got PFTs, which showed a restrictive pattern with low lung volumes, plus a disproportionately reduced DLCO. Physiologically, that's huge, because it points to impaired gas diffusion across a thickened, diseased interstitium. It's often the very first physiologic sign of interstitial disease.
But here's the number that really grabbed my attention. Resting in bed, her oxygen saturation was a borderline 92%. But the second we got her up and ambulating, just walking a few feet down the hall, her sat tanked to 86%. This exertional desaturation is a hallmark physiologic consequence of a wrecked alveolar capillary membrane. When she walks, her cardiac output shoots up, meaning her red blood cells have a way shorter transit time through the pulmonary capillaries. Because her interstitium is so thickened and diseased, oxygen diffusion is incredibly slow. So those red cells literally just don't have enough time to pick up oxygen before getting swept back to the left heart. It really underscores just how severe her gas exchange deficit is.
Now, digging into her environmental and rheumatologic review of systems, we found some seemingly random clues that actually cracked this whole case wide open. First, she keeps 2 pet parrots at home. Second, she reports a history of Raynaud's phenomenon, her fingers turning white, blue, and red in the cold, along with some pretty significant morning hand stiffness and puffiness. And looking closely at her hands, she's got this deeply cracked, hyperkeratotic skin on her fingertips and the sides of her digits. Classic mechanic's hands. We also took a really fine-tooth comb to her occupational and medical history, 0 asbestos exposure, and no offending medications on her list.
So, looking at all that, what clues are really hiding in this history? Before we just tunnel vision on her lungs, we have to step back and look at the whole patient. The subacute 8-month tempo points us strongly toward fibrosis or a chronic connective tissue disease, right? Not an acute infection or heart failure that would unfold over days. Her never smoking status makes a bunch of smoking-related interstitial pneumonias super unlikely. Then there's the parrots, which immediately raises the specter of chronic hypersensitivity pneumonitis. But what about the systemic clues? The Raynaud's, the puffy joints, the mechanic's hands? They practically scream at us to look for a systemic autoimmune process that's attacking her lungs.
Which brings us to part 2, the ILD framework. To make sense of all these competing clues, we really need to build this disease from the interstitium up to understand the rules of the game. Interstitial lung disease isn't just one thing. It's a massive umbrella covering over 200 distinct disorders, but they all share a common battleground, the interstitium. That's the delicate alveolar capillary scaffold where gas exchange actually happens. When that scaffold gets inflamed or scarred, lung compliance is destroyed. The lungs get stiff, non-compliant, and incredibly hard to inflate. So regardless of the initial trigger, all 200 of these diseases share a final common clinical endpoint, progressive inflammation and ultimately fibrosis of that vital scaffold.
The really crucial point here is the pathophysiology, specifically that transition from injury to permanent scar. It kicks off with an injury to the alveolar epithelium, which triggers cellular signaling that recruits an aberrant inflammatory response. At this stage, the immune system is acting up, driving inflammation. But, and this is key, it might still be reversible. The lung can still heal. But at step 3, we hit the point of no return, fibroblast activation. Once fibroblasts are activated and start laying down a dense, irreversible collagen matrix, the lung architecture is permanently wrecked. Established fibrosis doesn't reverse. Our whole job as clinicians is to intervene before that final collagen scar is laid down.
So, how do we tame over 200 different diseases? We sort them into 4 distinct buckets. Bucket 1, sarcoidosis and other granulomatous diseases. Bucket 2, exposures. This includes hypersensitivity to inhaled organic antigens, like bird proteins or molds, plus pneumoconioses from dusts like silica or asbestos and drug-induced lung disease. Bucket 3 is connective tissue disease, where a systemic autoimmune process like rheumatoid arthritis or myositis targets the lung. And the 4th bucket, idiopathic. And I really want to stress this for the students and interns on the team. Idiopathic is the absolute last bucket. It is a diagnosis of rigorous exclusion earned only after you've exhaustively ruled out the first 3.
This framework also beautifully illustrates how we read a high-resolution CT, or HRCT. We look at where the disease lives. Just naming the predominant zone instantly halves your differential. Upper zone predominant disease, that points us toward hypersensitivity pneumonitis, sarcoidosis, occupational dusts like silica and coal, or Langerhans cell histiocytosis. Lower zone predominant, that points toward a UIP pattern, which is classic for idiopathic pulmonary fibrosis, or IPF, as well as NSIP patterns, or asbestosis. We have to look at the zones to guide our reasoning.
All right, moving on to Section 3, Assessment and Treatment.
So, returning to our patient, let's reason through the competing explanations for her findings. We got her high-resolution CT, and it shows lower lobe subpleural reticulation along with traction bronchiectasis. That bronchiectasis happens because as the fibrotic scar tissue heals, it literally retracts, pulling the adjacent airways wide open. Most importantly, the radiologist called out early honeycombing in the lung periphery. Let's be totally clear here. Morphologically, this is a definite usual interstitial pneumonia, or UIP pattern. If you looked at this scan in total isolation, you'd say it looks exactly like classic idiopathic pulmonary fibrosis.
But remember our golden rule. Idiopathic is a diagnosis of exclusion. We sent off a comprehensive serologic panel hunting for an autoimmune cause, and boom, here is the twist. Her labs came back positive for an antisynthetase antibody. When you combine that positive serology with her extrapulmonary clues, the Raynauds and those cracked mechanics hands, the whole picture just snaps into focus. This is antisynthetase syndrome. Her pulmonary fibrosis is entirely driven by a connective tissue disease. It's CTD-ILD, meaning it was never actually idiopathic.
Let's pause on this comparison table for a second, because it highlights the most common radiologic fork in the road: UIP versus NSIP. UIP, or usual interstitial pneumonia, is dominated by coarse honeycombing with absolutely no subpleural sparing. The damage goes right up to the very edge of the lung. It's the classic pattern of IPF and usually carries a much worse prognosis. NSIP, or nonspecific interstitial pneumonia, is dominated by uniform ground glass opacities, and it characteristically spares that immediate subpleural space. NSIP generally has a better prognosis because those ground glass opacities usually represent active, potentially reversible cellular inflammation rather than dead, irreversible scar tissue. But our patient is tricky. She has a classic UIP pattern on imaging, but it's being driven by her autoimmune connective tissue disease, not by a truly idiopathic process.
And guys, this distinction isn't just academic, it literally dictates her survival. This is my central teaching point for the case today, the treatment fork. If we had just lazily called her UIP pattern idiopathic pulmonary fibrosis and stopped digging, we would have treated her with antifibrotics, drugs like pirfenidone or nintedanib. Now, those drugs are great at slowing the decline in forced vital capacity, but they do absolutely zilch for underlying autoimmunity. Because she actually has connective tissue disease ILD, the correct treatment is profound immunosuppression. Think mycophenolate or rituximab to stop the autoimmune attack on her lungs. Treating her for IPF with antifibrotics alone would have been a massive mistake. We'd basically be letting her immune system continue to destroy her lungs completely unchecked.
Now, beyond targeting this specific pathophysiology, we also have to layer in the supportive core care that every single ILD patient needs to survive, regardless of their specific etiology. She needs aggressive supplemental oxygen, especially given how badly she desaturates on ambulation. We're going to enroll her in pulmonary rehabilitation to maximize her functional capacity. We absolutely have to treat any gastroesophageal reflux, or GERD, because microaspiration just fuels more fibrosis. We'll routinely screen her for pulmonary hypertension with echocardiograms. That's crucial because lung fibrosis physically destroys pulmonary capillary beds, increasing pulmonary vascular resistance and eventually causing right heart failure. We'll also make sure all her vaccinations are completely up to date to prevent any acute viral exacerbations. And finally, given she already has early honeycombing, we're initiating an early referral to the lung transplant team, so she's already on their radar if things go south.
Which brings us to our final section, pearls and disposition.
So, closing the loop on her disposition and our concrete plan, she is stable for the general medical ward on supplemental oxygen. We are formally initiating immunosuppressive therapy today, starting her on high-dose steroids while we transition her to a steroid-sparing agent like mycophenolate. We double-checked her med list to ensure she's not on any sneaky fibrotic offenders like methotrexate that we'd need to stop. And while we don't think the birds are the primary driver of her disease, they are a potent inhaled antigen. So we've strongly advised the family to completely remove the pet parrots from the home to eliminate any superimposed hypersensitivity pneumonitis. We've also got rheumatology on board to co-manage her antisynthetase syndrome. Moving forward, we'll monitor her PFTs super closely over the coming weeks to see if we need to escalate to a second biologic agent.
All right, to round out this case, let's hit the absolute highest yield pearls for the team. Number 1, never ever write idiopathic in a chart until connective tissue disease and environmental exposures have been rigorously excluded. Number 2, broadly speaking, honeycomb UIP maps onto antifibrotic therapy, whereas ground glass NSIP maps onto immunosuppression. Number 3, always scrutinize that medication list for fibrotic offenders. Specifically look out for amiodarone, nitrofurantone, and methotrexate. Number 4, just like we saw with her drop from 92 to 86%, you must check oxygen saturation with ambulation, not just at rest, or you will completely miss the functional severity of the disease. And lastly, remember that the multidisciplinary discussion, or MDD, that formal meeting between pulmonology, radiology, and pathology, is itself the ultimate diagnostic tool. It's the modern standard of care for these complex cases. Which leaves us with one final, kind of provocative thought to wrap up our rounds today. If the term idiopathic is a label that's only earned by rigorous, exhaustive exclusion, how many of our current idiopathic pulmonary fibrosis diagnoses are actually just connective tissue or exposure mysteries that we simply haven't solved yet? It really challenges us to look closer, to ask that one extra question, and to examine every single patient's hands, their hobbies, and their history before we ever assume a scar has no cause. All right, thanks for your time attending. That concludes my presentation.